He told me after 6 months that tomorrow you'll go and join Dr. Karapurkar, who is a very senior teacher, renowned neurosurgeon, who was into doing the endovascular stuff back then, in the 90s. Neurointervention, we were in neurosurgery back then, will be handled by Uday Limaye under the guidance of Ravi Makant. You know, who does that? So such people, the giant people, actually changed my total scenario, and professionally, of course, and neurointervention-wise. The material that we used, what we go, say, to Paris and learn with Professor Moret, the same things were available to us, at least back in KEM, because we had a fantastic policy of importing. And the dean, my HOD was supportive, the dean was supportive. And so KEM used to import directly from companies like Target, Bolt. And so we had the same material which Jacques was using in Paris. We come back and we use the same. That was a huge advantage. Discussing complications, but they will also teach, which is not about complications, about the most advanced manner that they're doing in their departments, and of course teaching the whole world. So that's how the MasterSpeak happened, which was complicated case discussions was always there, and MasterSpeak happened maybe 2012 or 11. We started opening out our horizon, our own horizon, and so that's how the numbers increased. And so we didn't have too many things to look at.
Welcome to Getting Wired, Decoding Neurointervention, the podcast that takes you inside the world of cutting-edge neurovascular care. Hosted by Dr. Rajeev Sivasankar, a highly experienced interventional neuroradiologist, this series is dedicated to unraveling the techniques, innovations, and real-world challenges of neurointervention. Each episode features in-depth discussions, expert insights, and case-based learning from some of the most experienced masters in the field. From advanced procedural techniques to the latest breakthroughs, this is the go-to resource for specialists looking to refine their skills and stay ahead in the ever-evolving landscape of neurovascular intervention. Get ready to learn, explore, and master the art of neurointervention. This is Getting Wired.
Hello viewers. Today we are delighted to welcome to Getting Wired a person who is widely considered a pioneer of neurointervention in India. And not only is he a pioneer, but he's also a teacher to many senior practicing neurointerventionists in the country. Welcome Dr. Uday Limaye, very, very renowned neurointerventionist in this country and renowned globally as well. So welcome to Getting Wired.
Thank you, Rajiv. Lovely words as usual. And yeah, I'm so happy that I'm here with you in Getting Wired.
Thank you. So the main reason for having this session of this podcast was getting to popularize something which maybe not many in the country know, that you are the founder member of a meeting which is called the Monsoon Meeting, which is held in Goa. And that has been running now for, this is the 20th session we're going to be having this year. And it's been 22 years since its inception, but the 20th year that you're going to be conducting this meeting. So, but before we get to the Monsoon Meeting and how you came into with that idea, I just wanted to, for all of us to know that, you know, most people consider senior legends like yourself, like, you know, you were just born legends. But can you take us back to the beginning of the story, that how did you get into the field of neurointervention? And even today, many doctors, forget about lay public, don't know about neurointervention. So in your time when you were getting there, did you, like, was it destiny what took you there, or was it your dream, or how was it?
No, so I'll take more than a minute about this. And Because when you talk about the past at my age, it's like glorious past always. So, it begins with we wanted to be a radiologist for whatever reason. And while doing radiology, we got something called so-called interventional radiology back in the early 90s, which was doing some procedures to the liver, to the kidneys, maybe some angioplasty. And so that changed me, like yourself or many people. When you do something to treat the patient yourself, then you cannot go back to just being a diagnostic radiologist. So that was the first step, which happened in Grand Medical College. And then I realized that if I like this and if I have to continue this, then I have to join KEM, which was the only institute in Mumbai or Western India for sure, which was practicing interventional radiology as a separate unit. So once I joined KEM, then 6 months I was doing the same, the liver and the kidneys and angioplasties. And then my boss, Ravi Ramakant, he told me after 6 months that tomorrow you'll go and join Dr. Karapurkar, who is a very senior teacher, renowned neurosurgeon, who was into doing the endovascular stuff back then in the 90s. And so that's how I had no clue about, I knew that, something happens there in neurosurgery lab, but I didn't really have a clue about what neurointervention was or how it is done and how totally different it is from body IR. So that was the beginning. It just happened to me. I did not choose it.
Lucky for all of us and all your patients. So were there some, lots of people start their careers, lots of them take a shift midway or, a little detour here and there. Were there some, defining moments which in your career that made you want to do something more and more and more and took you deeper and deeper into it? Or were there some people who mentored you along the way?
Yeah. So, as I said, that I was shifted to neurosurgery to assist Professor Karapurkar. And from then on, my life changed. I mean, I don't remember that I'm not happy about something. Once you go back from spending the entire day at work and go back home, you are completely fulfilled. That started back then. And so after that, what neurointervention, so-called, that we were practicing then was minuscule. Because we did not have detachable coils, so we are not doing aneurysms. The giant aneurysms we were doing with just parentvessel occlusion, and then maybe angiofibromas, tumor embolization, and CC fistulas. So, 1, 2, and 3, these three pathologies was our 90% of the neurointervention that we were doing. So the defining moment happened when I went out to a Royal Perth Hospital in Australia for the GDC training. That was, I think, sometime in 1996. And so when I went to GDC training, I realized that there is much more to neurointervention and a completely different way of looking at and handling the same diseases that we were doing till that time. So I think that was the defining moment for me to realize that what we are doing is okay, but it is maybe 10% of, even then, the gamut of neurointervention. And the way that we are doing is probably not how it should be done. So that was what was the defining moment for me, self-realization, that we need to learn a lot and do much more. That was also the time that the GDC coils came just after a year to India for the first time. And so everything coincided. Everything coincided like an enthusiastic young person with dreams and starry-eyed, then have exposure to people who were at that time absolutely on top of neurointervention, like I went to Australia, and the GDC coils coming to India for the first time. So all these three things happened together, which absolutely changed my way of looking And ever since then, I think, we were more or less, if not with them, then just a step behind rest of the world from that time on. The people who were instrumental, there are too many, because, when in your life, there are so many hundreds of moments that you'll remember that, oh, this guy or this lady or this institute, it defined and it changed the way, just because what they did at that point of time. It changed the way and it changed your life, your career, and because of you, maybe indirectly, many people who came after you. And out of so many people, I would single out maybe four of them. First and foremost is my ex-boss, Ravi Ramakant, who had vision. He himself being such an intelligent and extremely talented interventional radiologist, he managed the department and he let people to manage specialties. And when he did that, he had the vision, he supported them to the hilt. And it was not without responsibility. He would say that this is your baby and you handle it. There were many instances that the responsibility as a junior lecturer, so-called, in KEM, it was too much for me to handle. But that's the way that he molded people. He saw a vision, and if he saw someone who could do it, then he supported that person to the hilt. So first and foremost, I will mention him. The second that I will mention is Professor Jacques Moret, because I was extremely fortunate in 1997 to go and train with him. Because as I told you before, that we were already doing many parts of neurointervention, or at least neurointervention, which existed back then. Mm. And so when I had to go to train, I was so lucky that I went to Professor Moret, who actually completely revolutionized neurointervention in the 90s. And I spent some time and then long time with him in 1997 and 99. So to be with him, to spend time with him, observe him, and saw the exotic, wonderful cases that he used to do back then also, that changed the way. That was actually my training, because, the official or the training which I was doing, it was actually because of Professor Moret. And because we were doing everything, you need not go and push a coil inside the aneurysm. Mm-hmm. Just watching him do it was good enough over a period of time.
Right.
So that's number two. And how did I go to Professor Moret? For this, I will credit again Anil Karapurkar, who I was going somewhere else. He said, but you're doing most of the stuff already. If you have to go, you have to go here. Mm. So, yeah, that was the right direction that I required. And he put in a word so that I got absorbed into his program for some time. And during that time, he actually had already shifted to Delhi. And S.K. Pandya, Sunil Pandya was the HOD of neurosurgery. So it was such, giant people who said that now from tomorrow, neurointervention, we were in neurosurgery back then, will be handled by Uday Limaye under the guidance of Ravi Ramakant. Who does that? So such people, the giant people, actually completely, I have to say that these four people changed my total scenario, and professionally, of course, and neurointervention-wise.
Mm. Wow, great story. So, obviously you did loads and loads of cases in those years, and you're still doing loads and loads of cases now. So, but there must be a huge, when you look back, a huge change in the era that we are in now, and the era that you were in at that time. So, at that point in time, what were your greatest challenges?
I'm so glad that you're asking me this question, because now it is so routine that you embolize AVMs or dural fistulas with onyx or what you have, or do coils, or do balloon remodeling, flow diverters, strokes. Whatever that we did back then, and I would go back to the 90s, whatever that we did was, it was not a norm. It was not like, okay, because I saw this 100 times elsewhere, or someone taught me to do this 100 times, I will do this now. It was not there. So everything that we did was the first time in our lives, and probably, if not the first, one of the first times in our country at least. So that's the huge difference that now it's commonplace to talk about doing a flow diverter or doing an intracranial stenting
Right.
or doing a stroke treatment, intraarterial stroke treatment. But what we did back then was probably right the beginning of that practice, at least in our country. So that's a huge difference, that there's nothing to fall back upon. You decide to do it, okay, you're lucky that you got exposed to some part of it
Right.
in where you trained or the meetings that you attended. But what you are doing is that there's nothing to fall back upon.
Right.
It's your call, it's your decision, you're doing it. Of course, I had fantastic help in KEM. And so forget about credit, but if something goes wrong, then definitely the blame is yours.
Right.
So it was Alice in Wonderland. We entered the gamut of neurointervention, which is now commonplace.
And what kind of machine did you have at that time? I mean, visualization must have been really poor.
Yeah, but we had BB29, which was a C-arm of Philips.
Right, I know that. Oh.
And so that was the DSA that we had, because our radiology machine was not armed with DSA. So that was the DSA machine that we had. We had to use that. And we got comfortable in working on that machine and doing every single thing, glue embolization and intracranial stenting, the first uniform that we used, the first sub-4 stent for aneurysm coiling in the world. And all those things were done on that machine.
Wow.
And because we didn't know better. And this is what we have. And it was not too bad. I cannot say that it was terrible, because some of the machines that I worked on after that, proper DSA machines, were actually inferior to BB29. So yeah, that was a challenge, but this is what we have. Our advantage, I must take liberty and tell you that, okay, machine was a small machine, but the material that we used, what we go, say, to Paris and learn with Professor Moray, the same things were available to us, at least back in KEM, because we had a fantastic policy of importing. And the dean, my HOD was supportive, the dean was supportive. And so KEM used to import directly from companies like Target, Bolt. And so we had the same material which Jacques was using in Paris. We come back and we use the same. That was a huge advantage.
Yeah.
Okay, the machine was not, but at least we did not struggle with material.
Right. But did you, because this didn't exist in the country, did you play a role in getting that stuff back to India?
No, you know what? There were only two companies back then, Target and Bolt. And Target made microcatheters. Coils KEM was not importing before. And Bolt was making detachable the detachable balloons. And so these were the only things which were available. And this was, the KEM was importing even before my time when Anil Karapurkar was there. So it was something, and we just suddenly increased the things that we were importing. And as long as she could, the dean, Pradnya Pai, they supported. And you would ask that, of course, it was municipal corporations' money to be used on not so affording patients of KEM. So then what was the payback? You know that it is expensive. Back then as well, it was expensive. So we had, with our social workers, we had a poor box charity fund, which anything, you would just put your money into the poor box charity fund, and the material was imported by that fund. And patients, if they had 10,000, 25,000, when the cost of treatment was $1 lakh, 1.5 lakhs, but they were paying as little as 25,000 for a coiling procedure back then. And so we had this liberty to, as much as the patient could, they could put the money back in PBCF, as we called it.
Right.
And so it was not started by me, but surely because our department increased manyfold, and we had, I cannot just talk about people who supported in every single endeavor. Our social worker was special. She worked as hard as us. We were doing inside the lab, and she was getting all the funds that we required. So many people who were instrumental in doing this.
Great. And in all this, where did the seed of Monsoon Meeting germinate?
It happened a few years later. So I've been attending all the meetings from 1997, and so the meetings which made impact, those were the only 2 or 3, 4 big meetings happening back then in the world. Link was one of them. The first Link started in 97. The World Desire meeting I attended for the first time in ABC Wynn in 1999. And of course, there was World Federation of Interventional and Therapeutic Neuroradiology. These were the biggest meetings back then, as they are now. And so, as the format of the meeting is concerned, the World Desire meeting made an impact in 1999. And then as you start, going, meeting people, attending meetings, going abroad, meeting friends, presenting your cases, where I came to know of this meeting, which was a complications meeting in Jackson Hole in Wyoming, the Wild West in the US. And that time it was not called as CCC, but it was just called as neuro complications, which included neurosurgery. So that meeting was by invitation only. So we were doing loads of work, and of course we had complications. But unless you were invited, you could not just go and attend the meeting. So the seed came in that, I am impressed by the idea. Why don't we do our own? Not that because we cannot go there, of course, because we cannot go there, but I like the idea. Why don't we start something of our own? So I don't know of any other complications meeting before the Monsoon meeting which existed back then, but the inspiration did come from the Jackson Hole.
And since then, of course, it's grown and grown. It's probably the oldest and most successful dedicated neurointervention meeting in the country.
Yeah.
And I would like to know why. I mean, were you not scared that, should I restrict myself to a complications only meeting? How will the fraternity look at this? Will they be scared in presenting complications? I mean, you were doing something very, very new in a specialty. On top of it, you have taken out a niche idea of being brave enough to show one's complications. So, but how was it? How was the idea taken?
Okay, so it was not out of the blue that we started this meeting. In 2002, we did our first INR workshop in KM. So that time we were a small community and we were like in touch with everyone. There were maybe not 5, but maybe 10, 12 people who were doing neurointervention. And for the meetings that we call you and bring your assistant or your students. And so we did 2002 INR workshop, which we did live cases from BV29. And they were sitting in the medicine seminar hall, which was the other side of the same floor. And so because of that, of course, we were all known to each other. And in 2003, finally, rather than doing one more live case kind of workshop, we said that we will start this meeting. Started very, very small, I should say. And we went to Lonavala. Everyone came by flight to the airport. And we had hired buses to take everyone from the airport to Lonavala, Duke Street hotel that was. And overall, along with our industry friends, overall there would be maybe maximum 35 people in that meeting. And since those 10 or 12 that I mentioned, those were also, all of them were senior to me. And so when we started this idea, they all were supportive. No one said that why should I show my complication in public? So they all were there, and it was never a problem to tell people this is what we are doing, and you or your juniors will have to come and show a complication or two or more. And they were all supportive. No one ever said that, no, why should I? No one. So it was not a challenge at all. Just the idea, maybe they appealed to them as well. And so once it started, then, then it became quite popular and bigger.
Of course. In fact, what's really endearing about the format of this meeting is that it is one of the best discussed meetings in sense of every case is discussed openly, honestly, and there is a kind of free-flowing throw about of ideas in what could have been done a little better and how could we have learned from that particular case or series of cases. So how do you think this, you brought about a cultural shift in thought process.
Yes.
And directly or indirectly it grew. So how do you think between then and now has meeting progressed?
Okay, so the first thing I would say that the idea of having free-flowing discussions and thoughts, that also came from my exposure to the Waldesai meeting, which is if someone has raised a hand, then you will be given the mic. And it's not like many meetings that we go, and especially congresses, that one question only. No time for discussion and questions. Let's just go. We are running behind time.
Right.
All those things were not part of our meeting. And they were not part of our meeting because, of course, I was hugely impressed by and inspired by the Waldesai meeting. So that's how it started. And then we were doing it. Then, it came to my attention that maybe not all the people who are practicing neurointervention, even back then, they are not entirely open or entirely at ease with the ideas at which some of us might be practicing neurointervention. And so it became slightly awkward for me and people like me or my department maybe to say the meeting is about questioning and commenting,
right,
and maybe even criticizing.
Right.
You cannot take that out of complications meeting. And so when it started becoming a little bit more that how can a few set of people get the right, so-called, to comment about every case which is being shown. This is where, not monotonous, the meeting can never be monotonous, but it became a pattern. And so I think we did this for quite a bit, 2003 to 2009-10, I think. And then I realized that we need to have someone who is respected by everyone in the world. And so that's when we started calling guests from out who were like renowned world teachers, professors. Professor Moray, he was our first one. And so that was the first big change which happened in the meeting. Complications only made 60, 80, whatever, over 2.5 days. Then we started inviting world professors, renowned people who are teaching the world, as a routine, sitting with you and talking, relaxed manner. Then I realized that if we are having such great people come and spend time, not just do their lectures and get out, why not make use of their vast experience? And so we started giving them the MasterSpeak lectures. So that's how the second change happened in the meeting, that it happened that those people are coming, we are discussing complications, but they will also teach, which is not about complications, about the most advanced manner that they're doing in their departments, and of course teaching the whole world. So that's how the MasterSpeak happened, which was complicated case discussions was always there, and MasterSpeak happened maybe 2012 or 11 that I started inviting them to our meeting. And so that's how slowly some changes have taken place. Now it's a set pattern. Every year there will be some addition or two. But the changes started back then.
Right. And do you feel that as you go forward, do you feel that the time has come, because neurointervention is also evolving in the country, and like you said, along with our hardware, our technology, do you think the Monsoon Meeting in its format will grow to have a different kind of spin-off, or will you grow, evolve to have smaller regional meetings, or do you have any thoughts for the future?
So, every year, you'll be surprised that every single year, no exception, every single year, I have a dilemma about what we are doing. Is it the sameness which is coming into it, or how can you make it better, bigger? And because there was a time that it was on autopilot, once few years, once we did successful first 3, 4, 5 meetings, then it was on an autopilot. Then it changed because we brought in new changes, because obviously it cannot become the same monotonous thing, and wire perforations, that kind of complications. And so when it started to change, there is a time that every year I have a dilemma that whether we should keep the same or do something different, which is bringing me to your question about the spin-offs, or doing it smaller, or taking to the cities. So this part I'm going to answer in two. One is smaller meetings, or maybe quarterly, 6 monthly, or taking to tier 2, 3 cities. Is when we started our monthly meeting in KEM back in 99, and that became autopilot. And so we were thinking back then that Mumbai was the only place where everyone was meeting in that monthly new INR meeting without any problem. But the other cities, for some reason or the other, could not replicate it. So I was thinking first to take that meeting, the Mumbai INR, to other cities, not just tier 2 or 3, or maybe even Delhi or Chennai. And so that we did 1 or 2 meetings like that, but that again was not to be continued for whatever reason. And so to do this meeting in a smaller format to other places, probably right now at least I'm not for it. But a new thought process is beginning, that what you're doing in Goa, in India, why don't you do it for the region?
Right.
So it may be our subcontinent or Asia, Southeast Asia. I mean, no other country has a regular routine complications or audit meeting like ours.
Correct.
So we may actually, rather than doing it smaller, I'm not saying do it bigger, but maybe take it outside India.
Right.
The subcontinent first, and then maybe if that is successful, then we may go into different cities in Asia. That's what is the current thought process.
Wonderful. Because I don't know if there are many fellows and residents in training or watching, may not be aware or haven't yet had the opportunity to come to a monsoon meet. The format of the Goa meeting is so unique. It's absolutely wonderful, because everything is broken down into not the theory of it, but into the practicality of it and the learnings from it. So if you haven't yet been to this conference, then I strongly urge you to make it a point to visit this. It's like an annual pilgrimage for an Indian INR at least, to visit this meeting every year. So coming back to the, we'll just zoom out a little bit from the monsoon meeting itself to the INR in India. You've been involved not only with the monsoon meeting, you've been part of the Circle of Willis meetings, you brought Mini Planet to India, you have organized, I remember in 2010, when you got the first penumbra with the separator and did a stroke penumbra meeting. So many conferences and meetings you brought to India, which have been great training ground for all of us. And like you've told me many years ago that Rajiv, every meeting, however big or small, you will always learn something from it. And that stuck in my head from that day. So just zooming out to the to INR training in India, do you think that currently it's become very easy, given that hardware has evolved? We can take even 7 French catheters up into the MCA. It's become so easy. Do you think that our training has some gaps that need to be addressed, or would you like to see training structured in some definite way for the better?
Yeah, I mean, see, when I was younger and I was more enthusiastic, and there were not too many training centers to learn and practice on a regular, hands-on, full-time, long-term fellowship in neurointervention. This was the year 2008, where we mooted. We wanted to promote some things that we were doing for all of India, maybe not like 20 centers, but maybe 5 or 10 centers, to have the same kind of curriculum, and centers who have minimum 2 full-time experienced neurointerventional professors, and then fellows training under them, and what they might miss out, because not everyone is doing everything, even back then especially. And so, to have the same curriculum, the same kind of period that they would be training, and then they should go at least 1, if not 2. They should spend a week or 2 weeks seeing what other people are doing and what is the way that everyone is practicing the same disease treatment. So this was an idea, and you had to do it with a society, and I tried, but maybe the time for that hadn't come. I don't know whether even today, if the time for that has come. What that would have done is that we would have engaged all the good and experienced people, teachers in India, to train people, So I'm not saying that didn't happen, but probably it didn't happen in a structured manner. So people got trained with various periods between a month or 3 years, 5 years. And so the period spent, the number of cases that you see, you assist, and most important, I should say, that the material is now advanced so much that it doesn't take too much training to get one catheter or a stent retriever or a balloon guide catheter inside Peter's ICA even. So then what is important? Strategy.
Absolutely.
Strategy is the most important thing right now that all the pupils and young students of neurointervention should know. And it should be the same standard which is observed everywhere. So I'm still largely happy because there are a lot of people who have come out trained. I would have just liked, maybe from the time that we wanted to do something about it, 2008 to now, it's well over 15 years, we should have established very uniform curriculum and guidelines about training in neurointervention. Because if you go right now, even our medical societies or Medical Society of India, Maharashtra, all the states, they are not aware of neurointervention as a specialty. Everyone is aware of IR, everyone is aware of neurosurgery, neurology, of course. Stroke is bringing it maybe a little bit more awareness, but still there isn't anything called neurointervention, a proper guideline. Textbooks, forget about it. Or if not textbooks, then maybe 20 senior operators in India taking 200 lectures a year for everyone who is training. Something like that can be done and should be done even now. They have now, because of the efforts of many good people, they have a D&B neurointervention which has started, which is good. But it needs to be all across very uniform, so that the people who come out of it are going to be almost of the same caliber. They are brilliant people and they are not so brilliant people. But you will have people who are trained equally. And that's how I think what I would say that it is probably missing a little bit.
Right. I'm glad you brought up that point about, the awareness of neurointervention, its kind of scope. So, coming back to, taking you back to the 90s and early 2000s, even if you look at the fact that even today you do not have this awareness amongst our physicians and surgeons, etc. At that point in time, how was the awareness? I mean, how did you get cases? Nobody knew about brain AVM embolization or aneurysm treatment. So how was the awareness at that time?
No, I would say it wasn't very difficult, because the first thing it started with us in the department in KM. Then I had an exclusively supportive boss. So I told him that this is the only, in public hospitals, this is the only DSA that we have. So we should not limit ourselves to KM only. So we should open it out to other public, municipal, government hospitals, and also other patients who are in private setup, who maybe neurointervention was non-existent there. And so they would come to KM, and then we got, of course, as God would have it, the fantastic biplane unit in 2002, which is great. So we had absolutely a brilliant Rolls Royce of a machine.
Right.
And people, even in private, they would come for our opinions. We would say that rather than going there, because that's, of course, maybe a better equipped hospital, but what we have, they don't have. So when we treat you, you will have to come into KM. So that's how we started opening out our horizon, our own horizon. And so that's how the numbers increased. And so we didn't have too many things to look at. So, if someone is doing something, neurovascular disease, aneurysm, subarachnoid hemorrhage, at least for the people who know about it, neurology, neurosurgery, they know about all these pathologies. So if someone is doing it endovascularly, they are going to know about it. If not immediately, then in a few months or a year. So the awareness in public wasn't there, but we were in KM, a huge public hospital with loads of patients, and they would come to the hospital, and this is the way they are getting treated. They need not be aware of, I need coiling only. Or like today, they go to all hospitals and say that I need thrombectomy because my patient has a stroke. So awareness-wise, patients didn't know much. And doctors, at least the doctors who mattered, they knew. They knew that this is how it should be done. And they all knew because, so initially I cannot say that it was a huge challenge to tell the neuro specialties that this is what we do and please send us patients. The patients kept increasing every week almost.
Right. And do you think that as far as neurointervention goes in India, for a youngster who is still sitting on the fence that should I take up neurointervention or should I go into some other field, what is your advice to them?
It's this question also has an answer which has two faces. The first one is that now we know that neurointervention, which was previously interventional radiologist who became neurointerventional radiologist, and then the neurosurgeons who became endovascular surgeons, and then the neurologists who became interventional neurologists. When we were training and we were in our own space, which was, as I told you, that it was a fantastic space to be in. And so since we were thinking about it, our concept of neurointervention as full-time actually was only in KM. There was no other department who were doing interventional radiology as an exclusive neurointervention. Maybe AIMS had two different departments of body intervention and neuroradiology, but they also doing diagnostic neuroradiology and neurointervention. Ours was the only center in the entire country which was dedicated neurointervention. And so maybe I was right or wrong, I don't know. I was of the belief that people should practice this as a full-time specialty.
Right.
Maybe I was wrong because full-time specialty, even today, there are very few people who are full-time 100% neurointervention only.
Absolutely.
No body IR, no looking at clinical side of patients, no sonography, no CTMR, very few. So today I would say is that for the young people who may be from radiology background, neurosurgery background, or neurology background, maybe you cannot sustain to begin with only doing neurointervention. Possible. So initially, if you feel that you will have to go rounds, take all kinds of patients in neurology, operate on trauma, operate on spine, subdurals in neurosurgery, and probably do body intervention as an interventional radiologist, they're not wrong. But in the same answer, the other face is that if you do something day in and day out, full time, you will get better in that thing. So, it's a simple thing. All-rounders are so rare in the world. So you may do this and you may do that and you may be good in everything, but you will be the master in one if you keep continuing to do that as your full-time specialty.
True.
And so this is what is the trade-off, that you do neurology practice as well as interventional neurology, neurosurgery, which is mostly is trauma, spine maybe, and endovascular neurosurgery, and body IR. I mean, one day you're doing something with the taste or something in the liver, or putting stent grafts for the abdominal aorta, and going to the brain and doing a complex dural fistula. Those things are not the same.
Right.
So I still feel is that you should get trained. You may practice according to what you feel because you have to sustain yourself. But if you're doing something, then you should be good enough to do that. You should not be having an idea, because I have the patient and then maybe I can do this also. So try to get the best that you can in neurointervention. That's what my passion is. So you spend your time, as much time as you want or can, to get yourself to the level, be the best neurointerventionist that you can be. That's what I will tell the younger guys.
And you feel that there is a large kind of scope for them, and the specialty is going to grow with more and more indications coming in, like venous sinus stenting, like CSF leaks, chronic SDH embolizations. We are only growing in our indications.
Yes, of course. And when we started out, maybe there were 5 business centers in India, and totally maybe, as I said, 10 or 12 senior practitioners. That has changed for the better, because the numbers are now huge, more than 500, 600. Is 500, 600 enough for the country our size and the population our size? It is not.
Absolutely.
And so my friend Raju, he always says more the merrier. So, I did not understand it back then, but now I do. More people, but only thing that we have to have some attention given to their training. And when it becomes, because of the medical societies and bodies and MCI, Government of India, if we can have dedicated guidelines towards training and then churn them out by hundreds, then India would be better served.
Right. Because just recently I was researching the numbers, and I was quite surprised when I extrapolated the data that, for example, just a simple disease like stroke, which is so highly prevalent, India should be doing about 2 lakh mechanical thrombectomies a year. Yeah. We are only doing around 4,000, which is a huge gap. And that's something which you can't do electively. So you need more and more trained operators, yes, like you said, in multiple tier 1, 2, 3, whatever cities. Right. So just coming back to the monsoon meeting again.
Yeah.
I just want to know, what are your thoughts on live meetings? Do you think it's a good concept to have? Don't we all learn so much is exciting too? And do you think there's space for live meetings to grow? Of course, we have to keep our legalities in mind. But as a concept, what are your thoughts on live meetings?
Okay, so forget about the permissions and legalities. I think because that's an endless discussion. We have learned from live meetings, like the first live meeting, which was the Link back in '97, and me, as in me, and maybe hundreds, thousands like me, we have learned from those meetings. So it is not something that no, it is not to be done. It cannot be, because if we were not shown cases live by our senior professors and teachers, even today they are doing so, then how would we learn? At the same time, I would say that doing a case live for a short group of people, which is how we got trained when we went to Professor Moray, as against doing that for hundreds of people, or doing it on a very large world stage, those two are quite different. Because what happens is that right now I go to many meetings and have been. So what happens is that some of the cases that, okay, we have a live case from so-and-so center. Let me not name centers or countries. What they have, with what they do, they will show it. We don't necessarily learn from every live case. And so maybe the format of making it bigger and 40 and 30 and 50 and a live case by everyone, maybe it is not necessary. You choose people who are at ease to do a case, give full justice to the patient, as well as do justice to the audience, 50, 100, whatever, 5,000 who are watching you, is difficult. It's an art. Not everyone can do it. Because first of all, so many people are watching you. It's okay that your staff or your juniors are watching you in your lab. That's completely different than a few hundred people watching you go live and do it.
Right.
So it's not the same. Doing a regular case in your lab versus doing the same case in your lab live, your heart rate is definitely slightly more. So there is a change. Many people have been doing it for time immemorial, so they are okay doing it and talking about it. But it's not the same thing as a routine to do this.
Right.
So case in box, a live recorded is the way forward. It is like, that's why you need, plus you don't have to go through the entire 45 minutes or hour of what is happening. You may finish the whole case in 10 minutes and have more discussion.
Right.
So live cases should be there, but maybe not by everyone, by very less people who have started this, the practice of live workshops, 2 or 3 great people that in the world. So maybe everyone doesn't have to do that, but everyone can record your case and present it as though it is happening live. Don't just show it as this what happened. Discuss it and take time, 15 minutes. I'm in the opinion or in favor more of the recorded live rather than too many live workshops.
Right. And for in India especially, it's difficult for young practitioners or fellows to go for international meetings, or to even sometimes go for national meetings, getting more and more expensive. So, which is one of the reasons, in fact, we started this podcast, so that we can have international experts talk about a certain subset of a disease, break it down. It becomes an educational platform. So, do you think that bodies should be taking this up, Like we have international bodies who have this for, say, Europe or the US, but we don't have such grants widely available for fellows in India. So do you think that something should be done in this regard?
Yes, and the responsibility is ours now, and young people like you as well, who are now very senior, and all of us. So the responsibility is that we should try and get them the avenue. We should try and get them the best possible classroom teaching that they can avail. And we should be making, and nothing is cheap, so we should be making arrangements so that it can be done. It can be made possible. So live meetings like we are talking about Monsoon Meeting all this time. Of course, it's expensive. But if you want to do something at a higher technical level and spend time over it, it's not just a 5-minute or talk that you're showing online, then that too takes a little, especially if technology is high, it takes money. And so we have to arrange in such a way that all of us are responsible to do this with the bodies that we have. Bringing in one more body or establishing one more society is probably not the way to do it. But all of us, in whatever background that we come with, we should get together and we should do this for our own people.
Right.
And then look at our subcontinent, the continent, and some people who might want it in some other parts of the world. It is our responsibility. We cannot look at someone else to do this for us.
Okay, that's a good, I think, thought to take away. 20 years. Running a meeting like this on this scale year after year is a huge task.
Yes.
How do you manage to sustain this? Where do you get the drive, the determination?
So this is also the time that, I must say that on my own, or our KM gang, who of course they are all the time for me back then and now, the first 2003, 2004, 5 and 2007, only first 3 or 4 meetings were done with complete responsibility on me and my team. Ever since then, we have been doing it through the India Neurointerventional Foundation, and where Sanjeev Gandhi is my partner. And so I think it's a very good thing, because there is someone for the too many things that you have to do a meeting, a successful meeting for so many years. And if you have someone who is not your competitor, but who is your partner and who is going to help you in every aspect of it, the academic part of it, the lecture part of it, and how the flow should go, maybe still it is our responsibility. But everything else, like we introduced event management after such a long time. And Gandhi has been, I think, very, very supportive. And so especially for Monsoon Meeting, I cannot say that there is no burden on me. But since 2007 or 8 maybe, he's sharing it in a very, very nice way. And so I cannot say it's a big burden, but still going forward, as I told you, every year I have a dilemma that what we should do so that it becomes engaging and people still look forward to it, learn something. And so we have these new things which we have introduced, and they will continue, like debates, or for camaraderie we have this quiz. This year we're going to have something like this, but a little bit 3 or 4 people, interviews on stage, and things like these we are introducing. And I'm not saying that we will do it, but as I already told you, that we will go outside India and involve people of our region, and maybe even think about maybe alternate years going back to the invitations only format, where we are calling the senior guys and the students.
Right.
And so there are so many things, the dilemmas in my mind.
Right.
I'm not struggling with them, but I'm thinking about it all the time.
Right. No, it's like I said, it's, I think, honestly, it's one of the best format meetings that we have in the world. And it is because of its honesty and free-flowing discussions that makes it such a successful meeting. So I think with that, I'm going to wish you the very best, and the Monsoon Meeting the very best for the next 20 years. Thank you so much, sir, for giving us your time. Thank you for not only this opportunity, but thank you for being there for so many generations of neurointerventionists and training them. And thank you for always thinking about the future. It was a pleasure having you on Getting Wired.
Great. And last 1 hour, hour and a half, I don't know, the time flew. It was most wonderful because talking to you on the subject that we love. Monsoon Meeting, of course, and neurointervention, the larger subject that we absolutely love.
Absolutely.
And so we don't have to prepare or read books and buy out something and come and talk about it now, because that it's all there in our hearts.
True.
And it was completely enjoyable experience.
We loved having you, sir. Of course, Getting Wired was initially conceptualized that we're going to decode a subset of a disease, and none better for AVMs than you. So you were my first choice for AVMs. But decoding neurointervention, a thought occurred to me, was not only about decoding a technique, was also decoding a neurointerventionist.
Yeah.
And none, again, better than you to decode, because sometimes in various fields we have certain legends. Youngsters who don't have the privilege of having walked closely alongside these legends would love to know about the persona and the stories behind them. So this was a very small attempt in getting them to know the Uday Limaye behind the legend. And I hope we could bring some stories to them. It might touch a chord or two and inspire more.
Sure, I surely hope so, because I can just go on talking about this for hours, and I hope that it was relevant. I wouldn't say useful, but relevant to the people like us, our juniors, and people who are just starting out on this great path.
I'm sure it will be, sir. But thank you again so much. A pleasure having you.
Thank you very much.
That's a wrap on today's episode. If you enjoyed this conversation, don't forget to like, comment, and share. And for more insightful discussions, make sure to subscribe the channel.